Today I'm going to talk about the single most important topic in medicine, as it causes 1/3 of deaths. 21 million people worldwide and 1 million people in the United States alone die of cardiovascular disease, or what should really be called endovascular disease, annually. Endovascular disease actually has two phases. One of them is the arterial and the other one is the venous. We're going to talk primarily about arterial disease, as it is the cause of most such deaths via heart attacks and strokes. So, as all of us know, cardiovascular disease, or rather endovascular disease, is caused by cholesterol. Cholesterol alone, we are bombarded with the information. We are treated for it, and it is expected that this is going to make us live forever, and none of us will die of cardiovascular disease. Unfortunately, it so happens that we have made almost no inroads into the disease because cholesterol is not the cause. And so I'm going to address and explain both the pathophysiology, the nature of the disease, and then give you some compelling reasons why I believe that the evidence is crystal clear that there is another culprit. So how did this whole cholesterol thing get started? Well, it got started with a brilliant scientist who ended up winning the Nobel Prize somewhere in the 1920s for chemistry, and his name is Alfred Windaus. And Professor Windaus was a meticulous and careful scientist who decided to study arterial plaques in 1910. And he published his information, which found that or his findings, which found that arterial plaques contain high levels of cholesterol, approximately 20 times the surrounding tissue. And thus it was concluded that cholesterol must be the cause of arterial plaques. This was followed up with definitive proof by a Russian scientist named Nikolai Anichkov, who fed a high cholesterol diet to rabbits who, lo and behold, developed atherosclerosis, which they don't normally develop, and therefore it was decided that cholesterol must indeed be a culprit. Of course, you do need to understand and remember that when you're feeding a rabbit a high cholesterol diet, you're feeding also a lot of fat. This was sort of ignored, and our profession, which takes up new information with the veracity of a conspiracy theorist, decided that this must therefore prove that cholesterol indeed was the causative agent for atherosclerosis. We didn't really have any means of proving these things further. We didn't have any treatment for atherosclerosis, so it kind of faded into the background until 1948, when a number of scientists on the East Coast decided that they should conduct a large-scale population study in order to look at causes of cardiovascular disease. And they selected Framingham, Massachusetts, which became a notorious study, or rather a famous, but should be a notorious study in our profession. And Framingham enrolled 5,200 people initially. Eventually over 15,000 people participated over the years. It was a monster study, lasted almost 40 years, generated mountains of data, none of which was published until the 1990s. What was published were digests and little bits and pieces of the data that were generated by statisticians, the first batch being in 1957, which looked at the association of high blood pressure and cardiovascular disease, and lo and behold, found a very strong association, a fourfold increased risk for people who had significant hypertension, defined according to the study. And they found that logically, if you had high blood pressure, then your risk of cardiovascular disease was increased fourfold. This is obviously significant. And it's also logical. If you overtax the circulatory system, pipes are going to go bad and they're going to burst. The same as the circulation in your house, in the pipes in your house. Or you take, for example, a car and you supercharge its engine, it's not designed for it, it's going to blow within a few miles. So this part certainly made sense. In 1960 then, they published the association with smoking, which was about threefold, not quite as strong as hypertension, but still pretty solid. And this started the whole thing about the smoking and quitting and all those things, and also discovering all the association with lung disease and cancers, which the tobacco industry had actually sort of obfuscated through diversionary tactics. So in this sense, the Framingham study was very positive. It also generated two treatable causes, although hypertension was still very poorly treatable at that point. The drugs we had, some of them were very, very potent, like syringoserpin, but very bad side effects. And so, but it gave us a potentially treatable cause. 1961, however, a new batch came out, and this touted the association between cholesterol and cardiovascular disease. The problem is the association wasn't nearly as strong. It was about a 1.6-fold increase in risk, and only mildly statistically significant. And also, as I explained, this was a result of digested data, which is a euphemism. It's really partially cooked data, looking for associations that may or may not be there. Nevertheless, at that point, based on the Windhaus information previously and the Anichkov study, all of a sudden, cholesterol became the causative agent. Why is this? Well, it wasn't quite as simple as those studies. In 1959 or so, Takeda Pharmaceuticals came up with the first cholesterol-lowering agent. This was in Japan. And so now we had a solution in search of a problem, and the problem, lo and behold, presented itself as a result of the Framingham study. So all of a sudden, cholesterol was the bad guy, and we had something to punch because we had a medicine, and it was a good medicine, didn't have a lot of side effects, although the liver didn't like it that much. And so now cholesterol became the bad guy. Also, at that point, we started pouring resources into trying to figure out exactly why the association was only 1.6-fold, and whether there was some other kind of cholesterol or agent or some subspecies that would be more predictive. And so we started looking at LDLs and VLDLs, and which are really particulates that are broken off, the chylomicrons, or the little blobs of protein that surround little droplets of fat, which is how fat gets transported in the bloodstream. You can't really have fat just by itself, because it would stick to the blood vessel walls, it would gunk up everything. So it's packaged into little droplets that are called chylomicrons. Parts of these chylomicrons break off, and this is where you get the LDLs and the VLDLs and all the things that supposedly contain all this cholesterol. It's really not a smart mechanism, it's more a physical fracture that just sort of happens. This is not planned by the body, contrary to what is claimed by some scientists. Regardless of that, cholesterol became the designated agent. Everybody else ignored other possible causes, even though cholesterol clearly is not responsible. And what is the ultimate proof? Well, if cholesterol was responsible to any extent, and if endothelial cells, or the inner lining of a blood vessel, had any particular susceptibility, then what would happen is that the plaques would be distributed evenly, and they're not. Now, some of us are genetic mosaics, so what happens is there's little bits and pieces of genetics from, let's say, another embryo that we inculcated into our genetics that never developed, but is supplying certain areas, for example, in your skin, in your intestines. We know that there are people who are genetic mosaics. Not everybody, but a lot of us do have this. However, cholesterol is in plaques which are discrete and localized in specific concrete locations, which are generally the same across masses of patients, masses of populations, and also different races worldwide. They're discrete. They're only in certain spots. How is that to be explained? Well, it can't be, certainly not with cholesterol. Furthermore, these plaques are streaks, and they're not transverse streaks. They don't go around the blood vessel. They go and point downwards along the surface of large blood vessels, not small ones. So they start in large blood vessels, and they rarely, if ever, progress downstream. So why is this important? The reason why it's important is because the only factor in blood that can explain this are platelets. And platelets are basically a non-entity. They're ignored by everybody. You ask one of my colleagues what they know about platelets, they'll say, most of us have between 150 and 400. They stop bleeding, and that's it. In fact, platelets are the most active, most complex, most unstable, and most prominent and most pervasive component of blood. What do I mean by unstable? It's very important. Unstable means that platelets get activated and discharge all the time for no reason whatsoever. This is very important. It's also important that we have way more platelets than we need, and it's in fact the only blood component, including cholesterol, that has a reason for being there and for causing problems. And that's because back in nature, we died from bleeding and infection, so we have a lot of platelets, way more than we need. Why is that? Because in nature, if you had a lot of platelets, you healed faster, you didn't get infected, and you didn't bleed to death. So we have a lot of platelets. But in nature, we never made it to the age where we would have heart attacks and we would have cancer and we would die from the bad things that platelets cause. There's no such explanation for cholesterol, no such explanation for white cells, no such explanation for anything else, because it's only platelets that kept us alive. Why this sweeping generalization? Because platelets are in fact the most important component in blood. A lot of people will say, well, that's a sweeping generalization, but it's what kept us alive. Platelets are the first line of defense for pretty much everything. If you cut yourself, platelets are the first to go there to plug up the cut and to make sure you don't bleed. If you don't have platelet activity, you're going to continue bleeding. As indicated, or as demonstrated, by something called Glanzmann's thrombasthenia, which is basically a bleeding disorder where you have deficiency of the 2B3A platelet receptor. 2B3A is a receptor which basically triggers platelet activation through chemical means. It's the mechanism whereby if you have an internal injury or you have an internal stimulus, the platelet gets activated. It is not the mechanism whereby the platelet gets activated to prevent you from bleeding from a cut. Not mostly. There's other mechanisms, but it is one of the mechanisms. Therefore, people with Glanzmann's will bleed, but they won't bleed to death like somebody with hemophilia. Hemophilia is a clotting problem. Platelet inactivity means you can't plug up the problem. So you can have a clot, but if you don't have a plug, the clot isn't going to work. That's the problem. So, you have to have some platelet function, otherwise you will bleed profusely and you could bleed to death like a hemophiliac. And you have to have a clot so that the blood is going to fix the plug into place. Both need to be present in order for you to be able to stop a large vessel bleeding. This is why we have so many platelets. People with Glanzmann's don't have this mechanism. And so I will talk about Glanzmann's a little bit later, but for now I will tell you the reason why I became interested in all of this is because my mom has a type of Glanzmann's which is not as overt as the main populations, which are Ashkenazi Jews. So there was in fact a person who seized on this disease and decided, hey, we can look at this and figure out, is our platelets in fact a factor in causing cardiovascular disease? Because people with Glanzmann's don't activate their platelets, and therefore they shouldn't really have plaques. So this scientist, Dr. Schlippmann, I believe is his name, decided to do a study on Ashkenazi Jews in Israel. And it wasn't a huge study because there's not a whole heck of a lot of people with Glanzmann's. But they looked at intimal thickness of the carotid artery, which is an index of do you or do you not have atherosclerosis. And lo and behold, they found they did. In fact, people with Glanzmann's have just as much endovascular disease as you and I. The problem is they don't have heart attacks, and they don't have strokes, and they don't die from their endovascular disease. So what does that mean? Does that mean platelets are not responsible? To the contrary, it's actually definitive proof that platelets are responsible. And later on I will also explain why current treatments don't work. So getting back to the whole thing of atherosclerosis, everybody assumes or they have some kind of a vague idea of what it is. And it's actually very simple. There's 3 layers to the blood vessel. There's the endothelium, there's the muscularis, and there's an outer connective tissue layer called the tunica. And this is all perforated by blood vessels. You don't really think about this, but tissues need circulation. Blood vessels are particularly vulnerable, and they have a problem because you cannot have perfusion while you're in the systolic phase. In other words, when blood pressure is at its peak, you cannot have blood going in there because the blood pressure inside the blood vessel is higher than it is outside of the blood vessel, by definition. So blood vessels are actually quite vulnerable to all kinds of insults. The other problem is the inside of the blood vessel is also corrosive. Because what does it contain? Blood. And blood is very corrosive. It's both chemically and biologically corrosive. What do I mean by chemically? I mean if you just simply expose some stainless steel to blood, it's going to corrode within days and become a mass of rust. You have the same piece of steel out in the air with a thin coating of oil on it, and they'll sit there forever. On top of it, you also have a lot of blood components that contain all kinds of corrosive chemicals, including proteins. Proteins can also eat away at you. So they can form bonds, they can take out little chunks out of various things, they can coat bacteria called opsonization, they can do all kinds of things. So these are biologically corrosive, hostile elements that the endothelium has to endure. For example, the immune system is not perfectly accurate, and if your immune system makes a mistake and starts attacking your blood vessels, then you have what's called a vasculitis, and this does happen. So the endothelium is the first line of defense and the last line of defense in the blood vessel wall, because the muscularis is not set up to resist the effects of blood flow. And this is where we're getting into what is the problem with the Windaus studies and the Anichkov studies. While Windaus was certainly brilliant for thinking up a problem that nobody else had thought of and then tackling it, at the same time, while he was gathering all these blood vessels and these plaques in order to be analyzed, he didn't think to actually examine those plaques. A scientist named Seymour Glagov did. In 1987, he published a study where he looked at the distribution of the plaque inside the blood vessel wall, and he found that the initial stages of plaque formation, the plaque did not progress into the lumen. What happened was, in fact, that the endothelium was broken down, And then the plaque started encroaching into the wall of the muscularis, into the layer of the muscularis. Subsequently, the muscularis then started taking up cholesterol in order to defend itself, fats, in order to defend itself. So this is why these plaques contain a lot of cholesterol, because cholesterol is one of the more chemically inert components of blood. And the body has decided that it's going to defend itself with the best weapon possible, which is cholesterol. Furthermore, it's going to calcify it. In fact, we know that a calcium index is an indication of your extent of cardiovascular, or rather plaque formation. However, what we also know is that high calcium scores are actually protective against cardiovascular events, because a calcified plaque doesn't break apart. It's stable. After a while, it becomes a very good defense. And after that, the blood can no longer erode further into the muscularis, cause any further damage. So this is basically what was going on when Windaus did his study. He found cholesterol because the body's trying to defend itself. We know that a lot of the plaques never end up being calcified, never end up being stable, and therefore they break off, and then you have a platelet plug that adheres to it and can block the blood vessel. This is how you have what's called a vaso-occlusive crisis. In other words, you occlude the blood vessel, and then whatever tissue downstream doesn't get supplied with blood dies. That's called necrosis. So, at this point, we know that platelets cause vaso-occlusive crisis, but what was not understood was that the Glagov phenomenon suggested, and it basically proved, that something in the blood was actually attacking into the blood vessel, and that cholesterol was actually the defensive response rather than the causative agent. Nevertheless, we have continued to insist that cholesterol is the causative agent, which it clearly cannot be. So what is? Platelets. And how do we know that? Platelets get activated by blood flow. Platelets get activated by a dimensionless number called Reynolds number, and we know that once you start getting around 2,000 for the Reynolds number, which is calculated based on diameter of the blood vessel, viscosity, and blood flow velocity, then you activate platelets because there's turbulence and there's shear stress. And so we have always known that plaques begin in large blood vessels. Everybody has plaques in large blood vessels first. They're all near bifurcations or slightly downstream from them. They all have a shape that indicates that it's an impinging jet, or it is a jet of activated platelets, which is not necessarily the same as impingement, which is that the jet is strong enough that in itself the velocity of the jet and the momentum causes damage to the structure of the blood vessel over time. So hopefully I'm not getting too technical, but basically what all this demonstrates is that, together with the Glanzmann's data, that platelets are in fact the causative factor and the initial damaging agent of the endothelium. Platelets also send out signals which subsequently exacerbate the situation, because platelets are the thing that start the immune response. Anytime you get injured, platelets send out what are called chemotactic factors that activate macrophages and activate leukocytes of all types, including natural killer cells and various other toxic agents. And those things then attack the tissue that has been damaged. Very often they cause a lot more damage themselves, in that the remodeling, it's called, is far in excess of what is necessary. The body does too good of a job, and through that it can actually cause a lot more damage than necessary, and can in fact structurally compromise the blood vessel, as proven by some of the aneurysms that we get in people with atherosclerosis, where the repair process actually weakens the blood vessel wall. It should also be noted that a plaque that develops slowly is far more benign than plaque that develops quickly, because the body has time in order to remodel blood vessels as well, and this is called neovascularization. And you also have collaterals, which means side blood vessels, and this protects the tissue downstream. So there are literally millions of people walking around in the United States alone right now who have significant obstructive disease, whether peripherally or in their heart, and they have no idea. They are not waiting to have a disaster because they have been collateralized. So why is all this important? The reason why all this is important is because platelets are treatable. We have a lot more platelets than we need. We only need about 20,000 in order to be able to endure a major surgery. So properly active platelets are in overabundance. We have, on the average, 400,000. Some people actually have more. I'm sorry, we have on the average about 250,000. Some people have a lot more, up to 400,000. Above that, it's defined as being abnormal, but there's actually people walking around with 500,000-600,000, no ill effects, other than the fact that they have platelets that potentially could be a problem. Now remember that platelet numbers alone don't define atherosclerosis. What decides is the ability of your endothelium to withstand the damage, and this is genetic, and then also your platelet activity, which is also genetic. So why is this? And it's also a factor actually of what your megakaryocytes are making at the moment. And if megakaryocytes get irritated, or if they get activated in any way, then they end up making abnormal platelets, which can cause accelerated damage. So why is this important? The reason why it's important is because most of platelet therapies have focused on inhibiting platelets. But this is not adequate. You can inhibit platelets from activating chemically or through the mechanisms, even bleeding. So aspirin is going to inhibit activation of platelets when you're bleeding. That's why you'll bleed more if you have aspirin on board, although the effect is minuscule in most people. Motrin as well. Unless it's a major surgery, most of the time it's not noticeable, and for a lot of people that actually do receive these drugs, they don't have the proper genetics, so they're actually resistant. So there's going to be no effect. On the other hand, we don't have anything that inhibits flow activation. And Glantzmann's proves that over 90% of activation is due to flow alone. So unless you actually inhibit the platelets from activating while they are flowing, and no chemical will do that, then you're going to have the same effect whether you're giving aspirin or not. That's why aspirin only has limited efficacy, both because a lot of people are resistant to its effects. In other words, genetically, they don't have the right receptors, but also because we're not inhibiting the flow activation of platelets, which is localized, and due to the Reynolds number, shear stress, and due to turbulence. The only way to do that is to remove platelets or to stop them from being produced. This can be done. We know now how to produce these, or rather how to eliminate platelets, which is called platelet pheresis. The problem is when you do platelet pheresis, you use a centrifuge and you activate platelets. On top of it, you also release these chemotactic factors which set your immune system on fire, as witnessed by the fact that we have to wash platelets to give them to people first. Now, the common dictum, or what we are told, is we're washing them because we're removing immune triggers. But in fact, we're not. What we're doing is we are removing the chemicals that are released by the platelets as a result of the platelet pheresis. And the most dramatic example of what happens with this is when you give platelet transfusion to kids. They have horrible, horrible side effects, high fever, and they suffer. They're in pain, uncomfortable because of platelet transfusions. No long-term ill effects, but it's still terrible to watch. It's also a demonstration of the potency of these platelets, because all you're talking about is just a few milligrams of material that are released by these platelets while you're separating them from the rest of the blood. So is there a way around this? Yes, you can take a hint from nature. If you watch the ocean, for example, or a lake, a quiescent lake, when there's bubbling, small amounts of bubbling and turbulence, then you're going to have scum rise to the top. So platelets are basically the equivalent of scum in the blood, and you can, with a bubbler, bring them to the top. They're also electrically charged, so they stick together, and then you can skin them and remove them. We also have some chemicals which prevent production. Unfortunately, they disturb the macrophage or the megakaryocytes, so your production is not very, it's somewhat dysregulated as a result. And so this is a problematic treatment because also hydroxyurea, which is one of the agents, has some long-term toxic effects on the bone marrow. And anagrelide, which is the other agent, which is somewhat newer and a little bit more benign, does cause tachycardia and can exacerbate congestive heart failure. So this is not a solution. Really, at this stage, we need to have mechanical separation. So why this video, and why this, what is the greatest acuity in terms of why we need some intervention? While potentially long-term, recognizing that platelets are the causative factor, or rather the triggering factor for atherosclerosis, is a potential 100% prevention and cure. Literally, it would be a disease that disappears if proper interventions were determined, and I don't think that they would be very difficult if we refocus from the garbage theory of cholesterol to what is really going on. The people that suffer the most are the ones that can be helped the earliest, and these are people who are on hemodialysis. This is the most astounding aspect of cardiovascular, or rather endovascular disease today, which is that we know that 100% of people on hemodialysis will have severe and eventually fatal circulatory problems. I cannot tell you how many people I have seen, their legs and their arms and various things chopped off as a result of vascular disease from hemodialysis. The Framingham study generated some further downstream data, and one of the forgotten things is that one of them looked at the association of gout with cardiovascular disease. And in fact, the association is stronger than either hypertension or smoking or cholesterol. So people with gout actually have the highest rate of cardiovascular disease. Very, very high. Over 50%. And people who get hemodialyzed not only have high uric acid levels, but also have high blood urea nitrogen levels before they get dialyzed. In other words, they have gout-like things in their blood. And because of that, their platelets get activated. Platelets get further activated in the process of hemodialysis. In the dialysis machine, in the dialyzer, you have what are called osmotic stresses. You have different concentrations of chemicals in the fluid. These changes are abrupt. The transit of the blood through the dialyzer is on the order of a couple of minutes at most. So in that time, the platelets shrink, expand, which activates them, 100% of them. And so they all get trashed. So people with hemodialysis or who are on hemodialysis have very low levels of platelets, and they all have very active platelets because even after they come away from the hemodialysis, their megakaryocytes then start churning out platelets at a rapid rate and in desperation. And so those platelets are abnormal. They're all pre-activated and they are large. So they have horrendous endovascular disease. It's basically like battery acid in their bloodstream. So why is this important? Because it can all be prevented. The major manufacturer of these things is Fresenius. And if they could be induced to start exploring whether they could have an extra circuit or a side circuit and separate the platelets, put them aside, and then give it back to the patient after hemodialysis, the odds are that we wouldn't see the terrible kind of disease that we do. Hemodialysis patients suffer. They get fevers, they have low blood pressure, they get infections. A lot of those infections happen because their platelets are dysfunctional. It is believed, or rather our dogma is, that it's because you can't be completely sterile with the administration of the hemodialysis as you're cannulating them. But that's not really correct. A normal person would be able to endure these assaults. They can't because their platelets are not functional. If we sequestered their platelets, if we put them aside and gave it back to them, and did not destroy them in the process of hemodialysis, a lot of the symptoms of the hemodialysis would disappear. They wouldn't be passing out during hemodialysis. And more than that, they won't die and they won't have amputations and have all the complications. They'll still have diabetes, which is the #1 cause of kidney failure. They're still going to have other complications, but they're not going to die unnecessarily or suffer unnecessarily. In the long term, I also believe that 100% of cardiovascular disease is preventable. And there's also a very good chance that some cancers are triggered by platelet activation, as they result in continuous tearing down and rebuilding of tissue locally, which selects out preferentially immortal cell lines, which is the beginning of cancer. None of these things have been looked at adequately. None of them have been looked at all, because we have been blinded by the cholesterol lobby, the cholesterol dogma, whatever you want to call it. So do I believe in a conspiracy? No, I don't think so. I don't think my colleagues, and I certainly don't think government, are smart enough. What I do believe in is Hanlon's razor, which is never ascribed to malice, what you can adequately explain by stupidity, and also Gresham's law, which is that bad information drives out good, because it's just easier and there's a lot more of it. So I thank you for your attention. I will continue laboring in my humble little way to disseminate this information and hopefully implement it as well. I did obtain a patent for a bubbler. It is now in the public domain. It's very simple to make. I believe it would work. It's not technically complicated. And like I said, I think the solution's already out there, and that's the shame.